Good evening, good morning, wherever you are. Welcome to the 23rd edition of SADS Facebook Live for the Sudden Arrhythmia Death Syndrome Foundation. I'm Mike Ackerman, genetic cardiologist at Mayo Clinic and president of the board of the SADS Foundation. And on behalf of Alice Laura, our CEO of the SADS Foundation, thanks for choosing to join us. Many of you have been with us every Friday since March, and we're delighted to have you back. And I am especially delighted to have one of the greats. I've called him, and you've heard me last week refer to him as the king of long QT syndrome. And he's not just that, he is a dear, dear friend. So Dr. Peter J. Schwartz from Italy, thanks for joining SADS Facebook Live today.
Thank you, Mike. It's a pleasure to be here. I will really enjoy the moments together, and thank you for your words.
Peter is joining us from the northern part of Sardinia, and we had to reschedule a couple weeks ago because he and his wife on July 9th celebrated their 54th anniversary. So happy anniversary to the two of you. And maybe you could give a little, make all of us envious and jealous about where exactly you're sitting right now over your place.
Let's see, I don't know if you can see it well, maybe like this.
Okay. That's beautiful.
Yeah, I think we are very lucky being here, yes. It's a hot day in Sardinia, but it's lovely to be by the seaside.
It's a special place to sit for our conversation today. And many of you know out in SADS Facebook Live land that we have been, because of the need out there in the COVID-19 pandemic, talking about things related to your genetic heart disease and the SARS-CoV-2 virus and when it causes an infection, COVID-19. And you know about the stats. We today have crossed 17 million cases worldwide, over 670,000 deaths. We've crossed 4.5 million cases in the United States and 152,000 deaths. You've heard me remind you that as a community of families with genetic heart rhythm conditions like long QT syndrome, CPVT, Brugada syndrome, and so forth, that we would together #refuse to fear, that we would do all the things that make sense. And I remind you, wash your hands, it works. Stay physically distant, it works. And put on your mask, they work. But that's all we're saying right now about Corona, because on this last day of July, July 31st, 2020, we all together are gonna have, guess what? A Corona-free day. So we're not going to talk about coronavirus, COVID-19, anything anymore. Instead, we're going to talk to Peter Schwartz, and have him take us back through history and stroll down memory lane together with your disease. Many of you have long QT syndrome, and so we are going to be very long QT syndrome focused for the next 35 minutes. Feel free to put a comment or a question that you might want me to pose to Peter, and depending on what we're chatting about, I'll glance over there and I might present it to Peter. But Peter, let's get started. I've said you're the giant. You are singularly one of the most significant individuals in this space of long QT syndrome, in my view and in my life. And I've appreciated so much of our touch points together. But let's go back almost pre my life, when my life began, to when your career began in long QT syndrome. When would that have started? What ignited the passion? What made you a long QT syndrome specialist in the first place, Peter? Take us to the beginning.
Mike, as it happens often, things happen by chance. Not chance alone, you've got to have a chance event occurring and then to be curious. What happened started exactly 50 years ago. In October 1970, there was a young lady, she was a 19-year-old. She was invited to be part of a live quiz program in Italy when there was only one TV program in Italy. So it was a program watched practically by the entire country. At one point, the anchorman turned to the young girl and asked her a question, and she realized that she was going to be seen by half of the country. And she jumped up and down and died suddenly in the real life situation. There was a negative post-mortem, nothing was found. The mother, the girl was living in a little village mountain. The mother had only elementary schooling, but she was a very clever woman. And she realized that this girl who died suddenly had already had a few events. She passed away a few times whenever she was getting worried, frightened, excited, or running. And she had another little girl by the name of Agostina, who was 9 years old at the time, who had exactly the same symptoms. So she discussed with the doctor in the village, and she insisted to have the girl taken to the University of Milan. And by sheer chance, she arrived in 4 beds where I was almost responsible of. I mean, I was 27 years old. So I found myself with this little girl. We had no idea about what she had. At that time, just 15, 20 cases had been described worldwide. And the only thing that was evident was that on her electrocardiogram, she had a very long QT interval. So I started pestering everyone in my department, asking what it was, and no one had an answer. But the director of my institute started calling me QT, PJQT, because I was going around with these ECGs. And it was clear that the sympathetic nervous system was involved, because anytime she was stressed, she would faint. So we started considering beta blockers. One day, when we had still no idea about the diagnosis, we wanted to perform an exercise stress test. And she was frightened. She said, I don't feel well, I don't feel well. So we made an ECG. And the senior cardiologist next to me said, oh, these are ugly T waves. I mean, I had no idea. I mean, I was never very good with the electrocardiogram, to tell the truth. And so he said, all right. So I started looking at what it was. Other doctors had no idea about what this was. And then I went down to the library. I mean, when in doubt, you go to the library. And then I discovered...
The library.
The library.
We have to remind some people about this library. That's sort of the place where you do some homework.
Yeah, exactly. That was the only way out. I mean, there was no PubMed. There was nothing. We didn't even have a fax, not to mention internet or something like that. Anyway, I discovered that this thing was called T-wave alternance, and was a very rare phenomenon induced by stress. So then I started looking. Eventually, we made the diagnosis of long QT syndrome. But I was lucky, because in the department where I was working, we were doing also very basic experimental work. We were working on the autonomic nervous system in cats, and I was able to reproduce experimentally in cats the same picture, the same electrocardiogram that this little girl Agostina had. So at that point, I became convinced that this was an important link. We started using beta blockers. Meanwhile, Art Moss in the United States had performed the first left sympathectomy, and which was very useful. And I started managing this little girl. 2 years later, she had several other episodes. And based on my cat experiments and some canine experiments performed by Frank Janowitz in Salt Lake City, I proposed to the family, to the parents, to do this surgery. And the parents said, why do you want to do that? And they said, well, there have been some dogs experiments in the United States and my cat experiments in Italy. And the husband said, the father said, well, I think you are a little bit crazy, but we trust you. So we proceeded on March 25th, 1973, we did the surgery. Agostina never had anything else. I mean, she never had any other event. I was the best man at her marriage, and she's always come to see me every year. And this is what started my interest for the long QT syndrome. And then, of course, from there on, I did a lot of experimental work to understand why taking out the sympathetic nerves on the left side was useful. And that was the beginning. So it was a chance event and a lot of curiosity, and the privilege to be working in a setting in a cardiovascular research institute where I could do things.
That's incredible. So 50 years ago is the timestamp. So a half century of taking care of patients and families with long QT syndrome, of doing that you described bench to bedside research before we called it bench to bedside. And in your case, it wasn't mouse to man, it was cat to girl research. And it's interesting, 50 years. So you've been through it all. You were in the pre-genetic era of long QT syndrome. At the halfway point of your career so far, 1995, the first long QT gene was discovered.
That was a shocking moment.
That was a shocking genetic area. And what was that like? I mean, what was that like for you to go from 1970 with your first diagnosis and patient to then having the gene discovered 25 years later?
Well, I can tell you easily because I will never forget that moment. Sometimes people are asked, do you remember when Kennedy was shot or these kind of things? And we all remember that. Well, I do remember vividly the situation because we had a house in Switzerland those days. I was skiing in the mountains, and late in the evening, Jeff Tobin from Houston called me and says, Peter, you've got to know this, and I don't want to go ballistic if you find it on Monday, but the first genes for long QT syndrome have been discovered. So next day I went, I was supposed to ski, but actually I did sit in the snow. I couldn't ski. I was just thinking that everything I had been doing for 25 years was probably going to be remembered as Stone Age work. So the only way out was to accept the situation that there were genes involved and to do something. And since by reading the first manuscript, it was clear that in one situation there was an increase in sodium current entering the heart, I thought, well, what about if we try to block the sodium current? And there was this older drug called mexiletine. And when I returned on Monday to the office, I told my people, let's call our few patients. We had a family with long QT syndrome type 3 due to the sodium channel dysfunction. I said, let's try to give them mexiletine. So we gave mexiletine orally, and the QTC shortened immediately. So I decided, let's send an abstract to the AHA. And my associate said, how can we do that with just 3 patients? And they said, you don't understand. This is the first gene-specific therapy ever. So we sent it, it was accepted. We wrote a paper which was published at the end of December 1995. And at that point, I was forced to learn and to study, which is wonderful. And I created my own laboratory for molecular genetics. I have a good group of molecular biologists. And of course, I'm totally fascinated by the power of these minimal changes in these small DNA changes that change the life of patients. And that is what started me on the genotype-phenotype situation, trying to understand why some of these patients were dying swimming or during an auditory stimuli or at rest. We couldn't understand it. And then progressively we began to understand a little bit more and then try to use it. So that has been a very fascinating part, but I must add that one of the beauty in our profession is the relationship you have with your patients. And I'm very lucky because in Italy, the way it works is that I have patients coming to me since 40 years, since 35 years, and they come once every year to see me. And since I don't do private practice, they come with their salami, with their olive oil, and they never came with a live chicken. But it's wonderful. And it's the relationship with the patients that is very important, because once I was frightened for my youngest son, and I was very worried. And I remember being in a place where doctors were just laughing and talking about stories while my son was being examined. And I'll never forget that. And so when I see patients coming to me with, they are frightened because some stupid doctors tells them your son can die in a minute and so on. I talk with them, I talk for them for a long time because I try to imagine sitting in their position and being frightened for someone I love dearly. And that is very important for the patient-doctor relationship. And as a matter of fact, it's a pleasure for me to work and to carry on in all these new fascinating areas, because the development, as you know very well, because all the work that you yourself have been doing and all the amazing work that Mayo Clinic has been doing, how fascinating it is, how intriguing it is. I mean, I go to bed thinking what I'll do next morning. I mean, how
Yeah.
can we work out this experiment? How can we understand what's going on? I mean, I think it's
Yeah,
wonderful.
I think you know, the privilege that you and I have to take care of these amazing families, they've blessed us richly. And I was going to ask you a different question, but you said something about the fear that they have, and I'm going to jump off to a question and have you encourage this person and all of our families. And so, Linda, thanks for the question. And Linda is asking Dr. Schwartz, can I live a long life with LQT2? I have an ICD. I feel like it's always hanging over my head. And could you encourage her that about how long QT syndrome might have been viewed as a death sentence in the distant past, but now you and I, we expect our families with long QT to live a long, long life without fear. Can you comment on that and give some encouragement to our families who still are afraid that their disease is going to grab them tonight or tomorrow?
I'm not going to encourage them. I'm going to tell them the truth. And the truth is that things have changed in a radical way. When we analyzed the situation in 1985 on 233 patients, all with symptoms, the mortality for those not treated with beta blockers or sympathectomy was 50%. It was less than 9% with those properly treated. Now it is 0.5%. So nowadays, almost no one should die with this disease. The combination of the treatments we have with beta blockers, sometimes exilitine, certainly left sympathectomy, and when necessary, an ICD, should really take everyone through so that they can die of pneumonia when they are 102 years old. I mean, I have LQT2 patients horse riding all the time, playing tennis. I mean, if the proper treatment is made with the specific adjustments in terms of dose and when to give it. For instance, for LQT2 patients, we always give beta blockers morning and evening in order to cover the moment of awakening, which is sometimes a moment of danger. So it's more specific, whereas for LQT1, we give it just in the morning. So we do adapt according to what we are learning progressively in terms of the gene-specific disease. But if you do a proper job, unless, there are exceptional cases, we all know
Sure,
that. There are some
sure.
mutations that are extremely severe. You know very well the calmodulin mutations. I never forget. I cannot forget my very first patient who's still alive. She's a beautiful teenager now, but when she was 4 months old and she was a calmodulin mutation, she already started having VF episodes, implanted with an ICD, many shocks. And I remember telling my people that these kids, in a sense, were not meant to live. I mean, they're alive because we have an ICD and now we can treat them properly. But now she's doing very well. So there are
Yeah.
situations that are very, very serious, but 99% of them, properly treated, can have a almost completely normal life. There are a few things that they should try to avoid, but besides that, I mean, it should have.
Yeah,
So
right.
Amanda, if that's her name, should have a normal life.
Well, Linda, I hope you're encouraged by the present day truth. I thank you for the question, Linda. And that's why at the SADS Foundation, one of our mottos, our vision, our expectation is for you all out there to live and thrive with your diagnosis, despite your diagnosis. So thanks for that question, Linda. Megan, thanks for the shout out. I'm glad you liked the videos. And Dana, greetings. Thank you for joining us from Ireland. Peter, I want to come back to your first quarter century of your career, the pre-genetic era, and maybe reflect on during those 25 years, what were one or two of the most significant papers you published that really meant a lot to you, and more importantly than meaning a lot to you, have meant a lot to our patients. Think about a couple from 1970 to 1995. Do any jump out as being pretty transformative for our families out there?
Well, I think that one of the things that became significant was that once I did my first left sympathectomy in my first little patient, Agostina, which again was following what HeartMOS has done in one patient, I didn't simply stop there. But then I spending a lot of time, many years, I think 7, 8 years, doing experiments in cats, dogs, anything that was possible to understand the mechanism and the implication of taking away this little nerve, in a sense. Because when we were able to prove that simply by removing these left-sided sympathetic nerves, it was more difficult for a heart to go into ventricular fibrillation, that meant that intervention was going to help not only long QT syndrome patients, but in theory, every patient at high risk for sudden death when the sympathetic nervous system is involved. We proved that for CPVT, as you know very well, and clearly this has now I would say almost everyone is doing it. You probably have the largest experience in the world yourself with left sympathectomy, and you know very well how this has improved the quality of life of these patients, because when a patient is at high risk and we fear that despite complete beta blockade, they are not fully protected, sometimes we do have to implant an ICD. I mean, I don't implant too many. I do it when I think is necessary. But very often the combination of an ICD as a safety net and sympathectomy to prevent the episodes is improving the quality of life in a very dramatic way. So the work that I've done experimentally to demonstrate and explain why cutting these nerves is saving lives, that I think was an important series of work.
I think it has transformed the care of our patients, Peter, and I thank you for, as you mentioned, your work really launched our denervation program for our patients. And I'll never forget one of our early denervations, because as you know, and our audience may not know, you were swimming upstream with autonomic modulation therapy, and people thought you might be a little bit, off the track with left cardiac sympathetic denervation, and you convinced me to try it. And we tried it on this woman with LQT2 who had received a dozen shocks in the 12 months before her denervation. Her life was ruined. She could hardly even move. She was fearful of the next LQT2 triggered event and shock. And I told her, we are going to try this denervation. And I'll never forget how the first month after the denervation, she texted me and said, no shocks, but still too early. The next month said, I wonder if this actually worked. The month 3 texted me and started describing things that she and her husband had resumed doing. And I said, okay, TMI, too much information. You are free to fly. And her life was restored, completely restored to where she could actually truly live again. And I think you have given not only saved lives with that work, but you've improved the quality of life of many of our patients. Many of our patients don't need denervation surgery either, but for those who do, because of your work, I thank you on behalf of them. Now, 1995 forward, the next 25 years or the last 25 years.
Not the last. It's only the second 25.
The second 25. The second 25. I'm just on my first 20. You're on your second 25. So your second 25 years, lots of papers and discoveries to choose from, but retrieve from the vault a couple of them that really, you mentioned the McSillatine in December 1995. That was huge. How about a couple others of the postgenetic phase of your career?
Okay. Before I do that, I want to make a comment on an expression you used a moment ago when you say that I was swimming upstream. yes, I was swimming upstream. I'm actually not a very good swimmer, but if I swim, I'd like to swim upstream. And it was for a while, I was sort of lonely. I mean, it was a lonely battle. A lot of people thought that I was a fanatic for this surgery. And it has been marvelous when I realized that you had joined and that you were doing it with such numbers. And in general, I don't mind fighting my battles alone, at least for the beginning. Then I'd like to be joined by someone. But that was important and useful. Now, the last 25 years, well, what I think has attracted me a lot was the work that I've been doing during the last 20 years in South Africa, where I spent 3 months per year, where I was lucky to study together with my partner there by the name of Paul Brink, a large series, a large family, all sharing the same identical mutation. I mean, that provided me with a unique human model because with more than 200 individuals having the same identical mutation, one would expect in theory that they all have the same symptoms, the same prolongation of the QT interval. And it was clear that the situation was different. Some of them, I mean, it was a serious mutation. 80% of them had symptoms and cardiac arrest and syncope, but 20% had nothing. And some of them had a normal QT interval. So that put me on the track for looking for what we then called modifier genes. Why is it that in a family you have two siblings with the same disease? One drops dead when he's 11 years old and the other one goes through life with nothing. So there must be something else besides the mutation that modifies the situation. So that has been my fascination during the last 20 years, I must say. A single paper, possibly the first one where we had the first modifier variant that we described was important, but it was a series. I mean, I think it was the concept more than a single paper. It was the concept of looking for those genetic variants, probably not very rare, that we all may have, that if I have them, don't change a thing because I don't have the long QT syndrome. But if I have the long QT syndrome, the same genetic variant may either increase or decrease the risk. So that was fundamental because during the last 5-10 years, we start working with this methodology, which is called the IPS cardiomyocytes, which essentially allows us to take a little bit of blood of a patient, transform that blood in the cells of the heart, and then study the cells of the heart of these patients, trying to understand why this patient is so prone to arrhythmias or is protected by arrhythmias, and looking also for new mechanisms of action, potentially new therapies. So this is a new area where I also have to struggle because, I mean, this is a totally new knowledge. I mean, I have to learn. I'm blessed by having a good group with students who can teach me a lot of things, but I'm fascinated by the questions, by the attempt to understand a little bit more, to make an additional step, trying to understand better why certain things happen to some patients and not to others, and how by understanding this mechanism we may think of devising new molecules, for instance, to provide a more specific therapy, even though I must say that on one hand, there is a fascination for the very selective therapies. On the other, it's simply in terms of common sense, there are measures that are very effective. I mean, beta blockers are not very specific, but they are very effective. Cutting sympathetic nerves is very effective. And even the ICD, which is very gross from a conceptual point of view. I mean, an ICD is the opposite of precision medicine. Still, it doesn't work. I mean, it saves lives. So there are a number of things that one can do, and I see a lot of work ahead, my friend.
Yeah, speaking of a lot of work, I wonder if you could comment on your next 25 years, or what about the next 25 years for the next generation of physician scientists. So I joined the staff of Mayo Clinic 20 years ago now, when I was 34 years old after finishing my training. What would you say to the next 34-year-old out there who's intrigued by genetic cardiology, fascinated by long QT syndrome, maybe just admitted their first patient in the pediatric intensive care unit or wherever they might have been, and now they're looking at that and saying, is there room for me in this field? What are the unanswered questions that need to be answered for the sake of our patients, for the benefit of our families out there? What would you say, in your vantage point, are the two most unanswered questions that you would be answering in the next 25 years, or that you hope my team does, or that you hope the next generation of physician scientists take the time and energy and passion to answer?
Mike, I begin to know you, and I was suspecting that you would have started with an easy question and end up with a very complex one. Now, before I try to answer, I have to say that you are referring to my next 25 years, and I'm afraid that I don't have 25 years in front of me. Probably, I have no idea, but that's unlikely. But for the time that I will have, I will certainly continue to work, and I'll tell you in which direction. And the direction is not too different from what I would advise young cardiologists. For young cardiologists, however, the main message I would like to say is, don't always trust your textbooks. You've got to find weakness in your textbook. You have got to go in a different direction. Very often in my life, I realized that the most important things that I was doing was because I was observing something that was not fitting with what was written in a textbook. And then instead of giving up, I was trying to understand and to move forward. So a young researcher, a young investigator who wants to be successful should not be shy, should be daring and trying to go in new directions. Now, in terms of the areas, well, genetics are opening such an incredible world. And as I do not have a genetic background, I mean, I'm a clinician with a lot of experience in experimental work, but the little I know about genetics is something that I'm learning day by day. I mean, I had to learn to survive in this new world. I mean, but clearly, at least, I mean, I don't know, I may not recognize the trees, but I see the forest, and I think I have a good sense of biology, and I see where things are going. The understanding of how a genetic variant works in terms of modifying the risk could be, in my opinion, one of the most important areas to develop. Because if we understand how a protective modifier works, and that is clearly going to be very different from the way beta blockers work or sympathectomy works, then we may understand how to try to modulate or modify the system at a very deep level, at a basic biochemical level, for instance, trying to go in a new direction? That, I think, is an extremely important question. Then an area that I would find important is to understand why certain patients are not protected by traditional therapies. I mean, therapies that work in 97% of people and don't work in 3%. Why they don't work in this 3%? So it's really I think we all have discovered, I mean, you and I and the others that have worked on long QT syndrome have understood a lot during the last 50 years. Progress has been wonderful, but there are still a lot of questions. And I think I would be looking for the oddities, for things that are out of the main path. That is what I would like to do.
Do you envision, Peter, a future without beta blocker therapy? Do you think we'll get smart enough at some point in time where we don't have to use beta blockers? Beta blockers work great, and you know that well. But there is a small subset of patients where beta blockers has profoundly affected their quality of life. We've called them, because they've called themselves, the beta blocker zombie. And do you think we're going to get smart enough in our therapeutic? I know Greg, who's one on SADS Facebook Live, is curious as to, will there ever be gene therapy for long QT syndrome? Do you see in your crystal ball long QT therapy where beta blocker is no longer the mainstay?
My crystal ball doesn't say that. No, I mean, we always knew that some patients with long QT syndrome couldn't tolerate beta blockers. For instance, I remember, but it was already, I think, in very early 80s that I sent my surgeon to Johannesburg in South Africa because there was a patient with long QT syndrome, a very serious situation with 5 members with syncope, and they were all with a very bad form of asthma, and they couldn't tolerate beta blockers. They not only they couldn't tolerate, they couldn't take beta blockers. So we did sympathectomy, and they did all very well. So there are patients in whom the antiadrenergic intervention by sympathectomy is sufficient. In general, unless we are really dealing with the patients you just described as a beta blocker zombie who can really not tolerate, and I had a few, not many, but a few. In those cases, I think I would use at least sympathectomy because you still need to protect them. In general, I prefer, if at all possible, that my patients take some degree of beta blocker, some dose, because I would like to avoid any risk. Of course, you have to balance it out. I mean, a good clinician has to look to the individual patient and try a few things. Gene-specific therapy sounds wonderful. It's difficult to predict. I mean, because then it goes down to mutation-specific therapy. And I mean, these will be a long discussion that you and I may have at some other point, because there are a lot of things that have been proposed, and I'm somewhat skeptical in terms of some of these gene-specific therapy being able to do better than the gross therapy that we are doing with antiadrenergic interventions. But certainly it's worth exploring.
Right.
We tried to silence the genes in LQT3 using mice and so on, but eventually we were damaging also the normal cells, so we stopped. So one has to be very careful when you enter in a new therapies, highly specific, that do funny things to the heart. Then you have to be careful, because there is also an old rule, Mike, that therapy should be gentle to the body, in a sense. And beta blockers, yes, they do have some negative effects for some, but in general, it's a gentle therapy. I mean, I'm taking a beta blocker for my blood pressure since 35 years, and I don't even notice it. I'm lucky, perhaps, but therapy should be gentle for the body, if at all possible, not too invasive.
Well, Peter, we have come upon the top of the hour, and this has been so much fun. And for those of you out in SADS Facebook Live, Peter is really one of the giants. This is why we are so much better at long QT syndrome in 2020 than we were in 1970. And it's precisely because of Peter and his passion and his work and his energy. And Peter, on behalf of all of the families out there, thank you for the first 50 years of your career. You, as we've talked about, and many of our followers may not know, not only have you been huge in the field of long QT, you're a giant. You are also, my friend, a giant in my life. You mentioned Jeff Tobin earlier in the program, and he is probably the single most significant United States giant in my life, who invested in my life and my career. And you did the same, and we've reflected together, and it's probably because I'm at the halfway point of my life now, where half of it has been without my father. He died 28 years ago when I was 26, and I think you have been like a scientific father. I think every child wants to hear their daddy say, "I love you," and I think every adult child wants to hear their daddy say, "I love you. I'm proud of you. You're doing good."
I love you, Mike. I love you, Mike.
No, but I think, Peter, I think you comfortably, either I assigned that role to you or you graciously accepted it. But I will never forget, from 30 years ago and then 20 years ago to the words of encouragement, the "that a boys" that you shouted out saying, "Well done, Mike." And thank you for choosing not only to invest in Long QT for the sake of our families, but thank you for choosing to invest in relationships like ours. And you are a treasure, my friend. And I leave you with any final words you might want to say to our community out there, and then I'll give them some announcements for next week.
Mike, it's difficult to respond to your words. It's been a privilege to spend this hour with you and everyone else. And to the patients with the long QT syndrome, they just should have a good doctor and be happy, because there are other things in life and they can have a normal life when they're well treated. And it's been a pleasure to be part of this program. Thank you very much.
Peter, thank you. This has been Dr. Peter Schwartz from Italy, now northern part of Sardinia, which he will return to enjoying a swim or time with his grandchildren or his lovely bride of 54 years. And for those of you in SADS Facebook Live, share this program to families out there. Next week, different time, back to our original time, 1:20 p.m. Central Time. This will be your time, exclusively your time, to have your questions given and answers provided by yours truly and others on specifically back to school issues. I know a lot of you are thinking about back to school. It should be an exciting time, not an anxiety provoking time. We're going to take questions about back to school. We'll take any other questions you have. So join us next week. And so until then, remember, refuse to fear, and blessings to you all out there. Take care. And Peter, thank you.
Thank you. Thank you all. Bye.